Um, you know, first of all, really, schizophrenia, the definition would be schizophrenia is a severe, I'm not happy with, severe, chronic, and disabling mental health disease that is often referred to as a severe mental illness, and severe mental illnesses will include schizophrenia, bipolar disorder, and other psychosis. Psychoses. In terms of the definition, obviously it's an SMI. It is indeed severe, chronic, and disabling. This is a mental health disease. The features of so we'll say with features, or perhaps we should say which is characterized instead before we actually talk about features. I think it's best to say it is characterized by psychosis. And when we say psychosis, we mean delusion, shall I say paranoid delusions, and hallucinations. So there will be psychosis, abnormal behavior, abnormal speech, and a reduced ability to understand reality, So in terms of the clinical picture of schizophrenia, again, this will, still fall under the definition. So the clinical features that one will find are normally grouped as positive symptoms and negative symptoms. So the positive symptoms will be the delusions and hallucinations, together with abnormal speech, abnormal behavior, and the negative symptoms really, and reduced cognitive function. And the negative symptoms will be seen as a reduced emotional responses to stimuli really, and withdrawal from social contacts. So if we were to go back, reduced ability to understand reality, there is also reduced cognitive function. And there are also psychological features, as well as anxiety and depression. So I suppose that is quite a wordy, but it's not really wordy, because if you were to sort of break it down, you'd have psychosis, you'd have the abnormalities of speech behavior, reduced cognitive function and all of that. And then you have the positive and negative symptoms. You would positive and negative symptoms. It's important really to mention that, you know, the clinical phenotype, as in the clinical presentation of the positives and negative symptoms will vary between patients. So not all patients will present with all of, you know. However, acutely there are more positive symptoms which are developed more acutely, and the negative symptoms have a sort of an insidious development, and they are seen mostly during the chronic phase, you know, in the later stages of schizophrenia, and they are associated with poor prognosis. So if someone was to already present with negative symptoms, that would be a worrying sign that, you know, the prognosis for, you know, is not very good. The important thing about schizophrenia, obviously, is that it can be treated, it can be managed, you know, and some people with schizophrenia can return to, you know, normal life, including working. It affects approximately 1% of the population, and, you know, some books say both men and females, the incidence in men and women are actually equal. The onset is around the ages of 15 to 35. So really we're looking at mid to late teens to mid, you know, to later 30s. So one of the most important features of schizophrenia in terms of, you know, when we talk about cognitive function, is that people with schizophrenia cannot. So in terms of reduced cognitive function, people with schizophrenia cannot perform executive functions very well. So obviously I'm talking about when someone is unwell. And executive functions are functions that are focused on attention, memory, and, you know. So what I mean about that, there is reduced cognitive ability in terms of executive function. I mean that when a normal person, for example, say is reading a book, and, you know, some unexpected noise happened, and when I say normal, I'm terrible, so I just mean that when someone who does not have a diagnosis of schizophrenia is perhaps reading a book, and there is a, you know, unexpected noise or stimuli, they can receive that noise, process it, and just grade it as unimportant to whatever function they are doing in terms of reading, and carry on reading that book. But when someone who has a diagnosis of, when that happens to someone who has a diagnosis of schizophrenia, they cannot, you know, block out all those unwanted stimuli. Therefore, there's a lot happening, and it, you know, it ends up obviously, you know, leading to the clinical features that are seen, things like hallucination, paranoia, and indeed, you know, that inability to perform, you know, cognitively, as in terms of, you know, there will be reduced attention, reduced memory. So the risk factors, just while I'm here, the risk factors for schizophrenia are both environmental, oh my god, I cannot spell environmental, environmental and genetic. However, there is no schizophrenic gene. There is no specific schizophrenic gene. However, it is known that, you know, if we're to look at, you know, the clinical features, the characteristics of this disease, obviously we've talked about cognitive function And we've also talked about things like hallucinations and delusions, and all these are linked to the dopamine pathways in the brain. And specifically, you know, the limbic and the cortical. So the mesolimbic, we should say, and the mesocortical. I think it's called the mesolimbic, or is it the mesocortical limbic? You know, when you put them together. However, the limbic really is mostly concerned with the reward pathway. And when we say reward, we mean, you know, when something happens and there is that euphoric result which makes, you know, the experience so enjoyable that one would want to do it over and over and over again. So it leads to a feeling of euphoria. And then there is the mesocortical, which is obviously concerned with executive functions, and I've already discussed that in terms of where am I? Oh yeah, there we are. You know, so in terms of the dopamine pathways, really, obviously, although there are, you know, 5 important, 4 we are usually concerned with, you know. So these ones will be, no, it doesn't matter actually. This is, you know, I just need to sort of not overload this talk, just make it as simple and straightforward. So it's the dopamine pathways. But the importance of this is that all treatments for schizophrenia, which are called antipsychotics, they target the dopamine pathways, and some of the newer ones also target the serotonin pathways. And really, I'll just very quickly say this, the importance of targeting the dopamine and the serotonin pathways is obviously that, you know, dopamine, as I say, it is involved, you know, in euphoria. So it is mostly a positive neurotransmitter in terms of it gives a positive reward. So it is a stimulus. So that's what I mean. And serotonin is usually called a modulator. So it's more of a modulating neurotransmitter. And the easiest way to think about it in terms of this disease is that, you know, if there was, they're all actually called G protein coupled receptors, which is something which I have here, but that doesn't matter. What's important really is that, say if you had a serotonin receptor, which is called the 5-HT2 specific for schizophrenia, that serotonin will bind that receptor, and obviously we are talking about neurons, you know. So when serotonin binds that receptor, you know, serotonin comes here, it binds there, it then causes release of dopamine. And then we have a dopamine receptor there. So the dopamine comes and binds onto its receptor there, and then it results in those euphoric effects. So really, if you were to use so if you know, you were to use a traditional antipsychotic, which are called the typicals or first generation, you know, antipsychotic, it will specifically bind on that receptor there and stop dopamine binding, so stop that effect. If we were to use the newer ones, such as clozapine, they are called the atypicals or second generation. They will block the binding of serotonin, but importantly, which I should have really used they'll block that. And importantly, they'll also block that. So it's like a double effect, and obviously, with that, if that is blocked, it means we don't really do that. And they also block that. So really, ultimately, the symptoms are reduced. So antipsychotics are really good at managing schizophrenia and other severe mental disorders, which I'm not really focusing on today. At the moment, I'm just focusing on schizophrenia. So really, my job is involved with, mortality in SMIs, and obviously today I'm mostly focusing on schizophrenia. And the mortality in SMIs, surprisingly, mortality when compared to people who have non-SMIs, the mortality in SMI is about, I think it's, I'm mixing the two, 15, people with SMI will on average die 15 to 20 years earlier than, people without SMI. And I think for schizophrenia, it says 10 to 25 years. So really, obviously this then makes you wonder, why isn't anything being done about this? Is there anything that can be done? And then in asking the question, can anything be done about this? We then tend to look at causes. Oh no. In asking the question, we would then need to look at the causes of mortality. What is actually causing people, with these conditions to die? So the causes will be the causes of this reduced mortality when compared to the general population are, conditions such as cardiovascular disease. There will be conditions such as metabolic syndromes. There will be conditions such as so whenever you say metabolic syndromes, it's, metabolic syndromes are 5 groups of disease, which will include hypertension, which will include obesity, specifically central obesity. It will also include hyperglycemia, hypertriglycerides, dyslipidemia, in fact, because it's all in the blood, and indeed reduced HDL. So for someone to be diagnosed as having a metabolic syndrome, they need 3 out of 5 of these. So because I've already said metabolic syndrome, sometimes I feel as though, should I then also say hypertension, because it is a risk factor? Should I then also say type 2 diabetes, because it is a risk factor? And then, obesity, should you then say it differently? And obviously, things like cholesterol. What else am I missing? And obviously when we talk about cardiovascular, we are talking about heart disease, strokes as well, and of course, you know, atherosclerosis. And indeed, you know, of course, you know, we can also, you know, write atherosclerosis here on its own, atherosclerosis. And and then you can still break this down even further to say, so what are the causes of, you know, things like obesity? It will be sedentary lifestyle, so reduced exercise. It will be, you know, poor diet, you know, perhaps increased food intake, food consumption. And then you can also, you know, say what are things that would cause atherosclerosis. So it will be things like smoking, you know, and again, obviously diet will come into that, as well as, you know, other, you know, other risk factors as well. So in terms of the causes, I like to sort of look at it as, you know, modifiable ones. Or modifiable. So things like lifestyle, risk factors. These will be things like smoking, taking exercise, you know, good diet, improving, you know, good diet, weight loss, and perhaps reducing food intake, but obviously, you know, on balance, have a, you know, a full nutritious meal, but not overeating, you know, not overconsumption, reduced overconsumption. And then, although I say modifiable, which makes it sound as though other things are not modifiable, what I tend to call all these other diseases, really, which is what's so sad about all of this, is because all these diseases, everything on here is preventable. It's preventable in the general population, i.e. people without schizophrenia. So now we look at the preventables. Preventable diseases. Which are all of those, you know? Because you can prevent cardiovascular risks by perhaps smoking cessation, changing lifestyle factors, you know, taking exercise, having a good diet, losing weight. One can prevent diabetes and indeed the metabolic syndrome linked to diabetes by, again, you know, improving diet, taking exercise, losing weight. For example, something like smoking. What smoking does, you know, is smoking causes atherosclerosis. And the atherosclerosis really just means that I prepared a talk on atherosclerosis in my medical videos, so if anyone wants to see that, it's available. All it means is that, you know, an artery is usually patent and open, and then when you have fat dispositions, which you know, the natural normal part of the body system in terms of good cholesterol, in terms of your immune cell. I don't want to include too much detail in this video. However, smoking causes atherosclerosis to line the arteries, in the sense that, you know, when an endothelium of a blood vessel is usually smooth and patent, And then when someone has atherosclerosis, there are fat depositions just under that endothelium there. So you end up with that narrowing of the arteries due to, this is what atherosclerosis is, really the narrowing of that artery. And what that means really is that when blood is trying to flow through that artery, which is narrow, you know, there's increased pressure for the blood to squeeze through there, and obviously then increased pressure for blood to flow through is really increased blood pressure, which is hypertension. So one can see how, you know, smoking will then cause atherosclerosis, hypertension, ultimately heart disease, strokes. Smoking also causes respiratory problems, problems such as COPD, such as cancers, such as, you know, a lot of other, you know, I'm only mentioning COPDs and cancers because COPDs, you know, is seen a lot in smokers. And obviously, ultimately, smokers will end up with cancers. But there are, you know, bronchitis, which obviously is COPD with emphysema. So really, smoking cessation, in terms of, you know, smoking cessation, it actually has a massive effect on reducing quite a few of the causes of increased mortality in schizophrenia. And then so in terms of the preventable disease, really, I'm not going to list them because these are all the diseases and they are all preventable. They are preventable by, you know, someone having a physical health check. So the mortality really is usually increased mortality in schizophrenia is usually caused by physical health problems. Oh, I should write this in red, in a color that actually is working properly. So mortality, increased mortality is usually caused by physical health problems. Which are all preventable, treatable. They are in the general population who do not have schizophrenia. However, with people with schizophrenia, there are less, you know, perhaps they don't engage with health professionals as frequently or as, you know, as well as they should, because, you know, these are people who are really unwell. So, you know, the onus then is on health professionals to make sure that, you know, physical health problems are identified and treated. And the way to identify them obviously is to undertake physical health checks, which will include taking blood pressure to see whether there is a hypertension there, blood, which will then tell us whether, you know, there is hyperglycemia. I think hyperglycemia is usually 11 millimoles. Anything above 11 millimoles per liter. Whereas, you know, DM, the diagnosis of diabetes is 7 anything which is more than 7 millimoles. And you know, elevated triglycerides, the diagnosis I think is 1.7 millimoles. So really, you know, and HDL, you know, we call this good cholesterol because it takes away the LDL, which is the bad cholesterol, and LDL is linked to atherosclerosis. So if you have reduced HDL, then you will have increased LDL and, you know, atherosclerosis, really. So both of these are cholesterols, but this is good. Then this is what causes, this is the cholesterol that will cause atherosclerosis. Obesity, obviously, you know, if you were to look at central obesity, I think this, in terms of metabolic syndrome, really, I must say central obesity, which is measuring the waist circumference of someone. And then in terms of, you know, diabetes, obviously the bloods, the glycated hemoglobin as well will need to be, you know, measured in terms of, you know, it's the most accurate. It gives a more accurate picture of, you know, the of glycemia in the bloods, because obviously it measures the red blood cells in terms of their entire lifespan, which is around 120 days, instead of just measuring the instant glycemia, which could be, you know, after taking a glucose meal, you know, it could be elevated in terms of if there is poor insulin release and poor insulin response. However, obviously, if you were to measure glycated hemoglobin, then you get a better picture. What else? Obviously, these are the cholesterols, and atherosclerosis obviously links into that as well as the hypertension, and really that is how one would then, you know, make sure that physical health checks are being undertaken. And if there is, you know, a problem, then surely, you know, medications such as statins, antihypertensives, you know, metformin in terms of diabetes, and, you know, weight loss, smoking cessation can then be, you know, offered to the patient in the hope that they will take it and mortality can be reduced. In terms of treatment of schizophrenia, I've already mentioned this, you know, there are the typicals and the atypicals. They both, you know, bind onto the D2 receptors, which are the dopamine receptors. And in some way, they also, you know, contribute to, you know, some unwanted effects. All medications do have unwanted effects. However, if all of this is monitored and checked, then surely it can be addressed. For example, you know, they would, you know, promote weight gain in terms of increasing hunger, and, you know, so if that is being monitored, then it can be managed properly. There will also, some of them will also have an endocrine, I don't know, okay, let's take, so some of them will also have endocrine effects that again can also be monitored. So we've talked, so, you know, there is, some of them will increase weight, that can be monitored. Obviously, as I've said, you know, weighing someone, taking that as a weight circumference, and then doing something about it, as in offering lifestyle choices, you know, and you know, weight loss, exercise, you know, taking exercise. Taking exercise doesn't have to be, you know, going to the gym. Just walking are things that will reduce weight in the long term. Some of them will also increase prolactin. And really, prolactin is increased simply because it is one of those hormones that are linked to the D2 receptors. So if you are antagonizing, blocking the D2 receptors, then it means that, you know, prolactin